Hello, everyone. I'm Abby. As you can probably tell, I am not Evan Adler, and I am not the chair of the committee. He's actually away today, so I get to play both host and presenter. If you can probably see, I am not in a clinic. I am at my house. I don't typically work on Thursdays. So if there are noises or things that are happening, cats running around, please just bear with me. Sorry. Evan did want me to, there we go. Just let you know that Therapy Thursday is brought to you by UNC Therapy Services and the Community Engagement Committee. In the chat, you can see the YouTube channel link as well as the Facebook page. So please visit and subscribe our YouTube channel and visit and like our Facebook page if you are willing and able to do so. Otherwise, I'm going to go ahead and get started. Okay, so a little bit about me. I am a physical therapist. I work at UNC. I am a pelvic floor PT specifically, so I'm a board certified women's health clinical specialist, and I work at the Hillsborough Clinic. I've been here at UNC for 4.5, working on 5 years, doing pelvic floor PT the entire time. I am a mother of one. I have a 6.5-month-old son. Luckily, my husband is home today, or else he would be guest starring in this presentation. So you probably won't see him unless something really goes wrong. I am also a pet enthusiast. I have 5 pets. Again, I mentioned this because I am currently at home, so you may see some tails or some animals scurrying about. Please disregard to the best of your ability. And then just a fun fact about me, I was born and raised in Alaska. I have made my way, obviously, up to the East Coast. I studied undergrad in Massachusetts, and then I came down here for grad school and have been here ever since. And I absolutely love North Carolina, but I also absolutely love Alaska too. All right, so today we're talking about diastasis recti, or diastasis, or abdominal separation. There's a lot of different terms thrown around when talking about the DRA, essentially. So what we're going to do today is go over the abdominal wall anatomy, talk about what a diastasis actually is, go over some risk factors, symptoms, and then some brief self-assessment tools, just in case you are interested in looking at your own abdominal wall, or somebody else's. And then we'll kind of get into the nitty-gritty of how do we fix it? Do we fix it? And then what is the role in physical therapy and rehabilitation interventions for a diastasis recti? And we'll also briefly go over myths about the diastasis. I only went over a couple. There are a lot. If you have myths or questions about it, feel free to put them in the chat. I don't have the chat pulled up right now, so I'll try and check it as I go, but I will absolutely check the comments at the very end. So definitely feel free to put them in there. Also, feel free to unmute yourself and ask questions as we go along as well. I'm definitely happy to answer things as we're kind of in the moment. So first, we're just going to go over the abdominal wall anatomy. As you can see here, there's actually quite a few layers. That little box in the middle kind of shows a window into the deepest core abdominal muscle. So the transverse abdominis is something that we as PTs are very intimately familiar with. It's one of our deepest core and abdominal wall muscles. We like to talk about it as the quote unquote corset muscle, because the way that it wraps around the body kind of looks like a corset and kind of functions like a corset, where you get this drawing in. And that's a really important function, first of all, for stabilizing the abdominal wall, the core, the back, but also in rehabilitation for diastasis. Then you can see the six-pack muscles there in the middle, and that is where we find the separation. We have 2 muscles on either side, and in the middle we have the linea alba, which is a dense connective tissue that adheres those two muscles together. And then further out, we get to the obliques, the internal and external obliques, and those live a little bit more on the side of the trunk as opposed to in the middle. But I would be remiss if I did not talk a little bit about the pelvic floor in relationship to your core and your abdominal wall. So we've removed those front abdominal wall muscles, and now we're talking a little bit more globally about the core, because when we talk about the core of our bodies, we don't just mean your abdominal wall. We also mean the top, the diaphragm. We mean the bottom. We mean the pelvic floor, as well as a lot of your back muscles. And so here you can see an internal representation of your back. A lot of those muscles are hip muscles. You can see the diaphragm here. I don't have a picture of the back muscles, but those are also an important piece of core musculature. And they are all really important in stabilizing your back, your trunk, your hips, your pelvis. They're very fundamental and important foundation for your body as a whole. We also like to talk about how the abdomen and the core kind of function like a soda can. So you can kind of see the soda can off to the side as well. And it's very important in controlling our intra-abdominal pressure. So an abdominal wall, a core, the thoracic musculature, if it is working properly, you're going to have a lot of equality in your muscle strength. So the back muscles are going to be as strong as the front muscles, as strong as the diaphragm, as strong as the pelvic floor. And when all of those are in an equilibrium, then you can really maintain intra-abdominal pressure, kind of like a soda can that is still closed. If you try and squeeze a soda can that is closed, you're not going to do much damage. It's not going to move at all because all of that pressure is well maintained in all different dimensions, the top, the bottom, and the sides. However, if you pop the top on that soda can, and if you go ahead and try and kind of crush the can at that point, you'll be able to actually make a dent, kind of deform the can a little bit. And the core really functions in the same way. If we have an imbalance in the muscles, then we can see dysfunction, not so much deformation, but dysfunction in different muscle groups. If we have an area of weakness, such as like connective tissue weakness, you can see dysfunction or poor control of the intra-abdominal pressure. And that's an area where there could be not only dysfunction, but possible, in some cases, herniation. So for example, say like an inguinal hernia, if there's like connective tissue or muscle that has a little bit of a hole in it, if we don't control our intra-abdominal pressure, we can get protrusion through that area. And so that's why working on the entire core mechanics is important. So what is a diastasis recti? In its simplest form is a separation of the abdominal wall between the rectus abdominis. So the very top left, my left, hopefully it's your left too, picture is an abdomen without any separation. So we're looking at the rectus abdominis, and they're more commonly known as your six-pack muscles. And typically, there is the linea alba in between, and they are fairly close together. If you were to feel this first rectus abdominis, there really wouldn't be much change between the two muscle walls or muscle layers. It would feel almost like they were pretty synonymous. They kind of, you can't really feel a gap between them, essentially. There's a lot of different variations in what a diastasis looks like, and this goes over the different types of separations that you can see. The first one, the middle top, is the separation just around the umbilicus or the belly button. So you can see it kind of forms a little bit of an O right in the middle. The next one, the top right, is separation just below the umbilicus or in the lower half of the abdominal wall. Bottom left, you can see that there's just a separation above the belly button. And then the last one, bottom right, is a full separation throughout the entirety of the muscles of the rectus abdominis. So you can really get a separation anywhere. It's not always the entire length of the muscle. Sometimes it's just the top, just the bottom, or just the middle. So some risk factors. One of the most commonly known risk factor is pregnancy. Fun fact, I think there is an article that states that if you have gone past 35 weeks of pregnancy, you have a 100% risk of having a diastasis. So it is supposed to happen in pregnancy. What we're typically looking at is after pregnancy, trying to see how well they come together or how well you close them. Or at least that's one of the thoughts. Having 2 or more pregnancies that are close together, so back-to-back pregnancies, not having a chance for those abdominal muscles to re-strengthen, rehabilitate. Not listed, but also as a risk factor is multiples. So if you are pregnant with multiples, you will have a higher risk of having a diastasis as well. Obesity or increased abdominal or waist circumference is also a risk factor. Poor core and abdominal strength, as well as doing sit-ups or weights improperly, are also risk factors. I put little asterisks there because I don't think that they are as significant of risk factors as the first couple. However, they can absolutely happen. I tend to see, this is more anecdotally in my personal practice, I tend to see a combination. So there's poor core strength or doing some of these activities improperly, and pregnancy and postpartum and increased waist circumference. That's not always the case, but that's usually what I see. Another thing that you may be interested to note is that babies have a diastasis. So when they're born, they have poor core strength. As they develop, that separation actually comes together. And so that's one example where poor core strength is usually united with a diastasis. And then lastly, abdominal surgery. So that can mean C-section. That can also just mean any abdominal surgery in general. Can be a risk factor. Oftentimes I'll see if there is a kind of a linear incision. If that hasn't healed very well, sometimes that can cause a separation as well. But it's all very dependent on different people, different connective tissue. So some symptoms. One of the hallmark ones for people who have a diastasis following pregnancy is more that abdominal pooch or stomach bulge that you'll see. And so this picture right here is a good representation of that. You can kind of see a separation, but what's more prominent is more of kind of like a circular pooch that kind of develops. But that's not always the case. I have a lot of people who don't necessarily have any stomach bulge or pooching that develops with the diastasis. Lower back pain is definitely a common symptom. And one of those big reasons is, if we go back to talking about the abdominal wall and the core and how it functions all together with the back muscles and the diaphragm and the pelvic floor, is we need that core strength and support for our back, for our pelvis, for our SI joint, for a lot of those different areas. So if your abdominal wall is not as strong or functioning as well, we can see a lot of low back pain because of that. Poor posture, again, goes hand in hand with having decreased core support or strength. Constipation and bloating, those are a little bit more surprising, I think, to most people. But if we don't have really good integrity through the front of the abdominal wall, then we can actually see, especially bloating, where the abdominal wall can't really contain a lot of that pressure well, and so it'll bloat out. And you can see that in response to your GI function. And if we don't have really good tension and integrity through the front of the abdominal wall, that can also affect our GI function, our motility to a certain degree, where you actually need that abdominal wall activation to help move stool down. So that's actually a really important piece. Okay. So ways that you can assess your own self, or somebody who comes to you, or if you're a physical therapist on here, like some ways that you can assess patients. Number one, observe the abdomen. That will just tell you quite a bit. This picture right here, you can see that there is some doming or some coning that's associated when he's doing, in this person, it's a male, when he's doing an abdominal crunch. So if he's lifting his head up, you kind of get a little bit of a protrusion through that separation. You can also see the opposite, where there's actually some caving in as well. There's a picture later on in the slides that show a good representation of caving through that separation. I would say doming and coning tends to be a little bit more prominent and prevalent. That's usually what I see, but that's a really good hallmark of having a separation or just having really poor control of your intra-abdominal pressure, which tends to go hand in hand with a diastasis. But you can also measure the gap yourself. So what you can do in order to measure the gap is lie down on your back with your feet bent, and you can do this in one or two ways. You can first lift your head and shoulders and then take fingers. So I usually take 3 or 4 and you place them right on the belly button. Kind of, I don't know if you can see me, but this way. So across, more transverse. And you're going to measure how many fingers live between the 2 abdominal walls. You can also just put the fingers there before you do the crunch and then crunch up. And sometimes you'll feel no gap. Sometimes you'll feel there's 1 finger that lives in between there. Sometimes there's 2. It can go as high as 4 or 5. There's a big variability. Typically, when I am assessing, I look at the separation at the belly button. I usually go about 2 inches above the belly button, or about 2 fingers, maybe not quite 2 inches, but 2 finger widths above and 2 finger widths below. And you can see if there's a separation at any of those spots. And why we do that is because you can see separation at different areas and it can be variable throughout. But that's probably the best way that you can do this on your own. This is certainly what we're doing in the clinic. So here we come to how do we fix it? And to be honest, a better question is now, do we have to fix it? We're kind of living through an evolution of theory for diastasis rehabilitation, essentially. The previous thought and the previous research really looked into closing the gap. And for a long time, that was the primary goal and objective that we had. In the last, I'd say 20 years, research has started to focus more on looking at abdominal integrity and making sure that you are activating your core muscles appropriately, controlling your intra-abdominal pressure, and actually tensing the tissue between the separation. So that linea alba, making sure that we're tensing it well. And sometimes that is correlated with closing the gap, and sometimes it's not. So there's actually a lot of different information out there. If you do a Google search, you're going to find a lot of different advice. And one of the reasons why there is so much variability in the advice and the recommendations out there is because we're kind of living through this evolution of a change in the theory behind how we want to address the abdominal separation. So do we have to fix it? Currently, the answer is no. That's really not going to give you more functional status. You're not going to be able to do more or do things better if you don't have a separation. If you have better core control, if you can control your intra-abdominal pressure, if you can tense those tissues appropriately, that's where you're going to see a lot of your functional improvements. And that's how we're going to see the ability to get back to activities that you want to get back to. So that kind of leads into that second bullet point is learn to control your intra-abdominal pressure. That's a big one. We need to use our muscles appropriately if we're actually going to control that pressure. And that's how we're going to reduce that doming, but also that concavity by using those muscles to tensile that tissue so that things are stable, so that your core is stable, your pelvic floor, your diaphragm, your back muscles, they're all working together. They're all working synergistically. And that's going to help you stabilize your back, your abdomen, your SI joint, your pelvis. So that's really where the importance is. So another thing is avoiding activities that can contribute to the separation. Yes and no. So we're going to avoid a lot of activities in the beginning if we're not controlling the separation or the pressure very well. So I'd say that's a little bit of a it depends situation. We don't want to make things worse. That is absolutely obvious. We don't want to make things worse. So in the beginning, we're really trying to show people how to move in ways that don't create that doming or create that pressure going through the diastasis. However, as people progress, as that intra-abdominal pressure regulation gets better, as your core control gets better, we actually do want you to be able to get back to activities that that maybe in some people can contribute to the separation, but you have learned how to control through abdominal strength and stability. Physical therapy, that's one way that we can help fix it. Abdominal support bands can also be another area where you can help to control the pressure. That's another area where I say there's a little bit of a caveat. Abdominal support bands function a little bit more like a Band-Aid over the muscles. So they are doing the job that your muscles are supposed to be doing. So there's a good time to use them and there's a not so great time to use them. Essentially, they're really good if you need to do activities that maybe you aren't strong enough to quite do on your own yet. A good example of this is lifting really heavy things. So say when you're lifting, you just can't control that pressure very well. Putting an abdominal support band on during that activity may actually be really helpful because it's going to give your abdominal muscles the support that they need to maintain that integrity. Sorry, my dog is being a little whiny. I might let her out in just a second, so bear with me. But the important thing to know about the abdominal support bands is that it's not something that you should wear all the time. We do want your muscles to learn how to function and strengthen your abdominal wall independent of a support band. So it's important to know kind of when to use it and when not to use it. That goes as well for kinesio tape. It functions really similarly to the abdominal support band. It gives you a little bit of abdominal support. However, KT tape is also designed to help get your muscles to activate. Hold on just a second. Okay. And last but not least is surgery. So surgery is kind of a last effort to close the gap. Like we talked about before, do we actually have to close the gap? No, we don't necessarily have to. There are plenty of people that I have seen who have a separation that is maybe greater than 2 fingers. 2 fingers being kind of the, if you are 2 fingers or under, that is considered a normal separation. If you're above 2 fingers, that's typically where it's considered abnormal, or at least it was. So if we've worked on all of these different things, we've worked on controlling intra-abdominal pressure, we've worked on getting the core and the abdominal muscles to tension the tissues appropriately, and we've even done maybe some exercises designed at closing the gap, and we're still not seeing a closure, you can be fine like that. However, if it's cosmetically it's just not palatable to the person, surgery is a really good option to close the gap, but it tends to be more for cosmetic purposes at this point. So PT specific, what can you expect from physical therapy if you are coming for a separation of the abdominal muscles? First, we're going to assess your abdomen, your abdominal wall, your hips, your low back, your pelvis, your pelvic floor. And that's one of the reasons why I really wanted to go over not just the abdominal wall, but all of those other muscles that are contributing, because we are going to take a look at them. They're all important in rehabilitating the diastasis and just improving your core control as well. We'll go over learning to engage your deep core muscles appropriately. We'll also go over some exercises designed to help close the separation. So we still do that. And a lot of this is really goal oriented. Some people come into the clinic because they have a separation and they don't want a separation. They want to work as hard as they can to close the gap. And we can absolutely try and close it. Typically, there's about a 50% chance of us being able to actually close the gap or bring it under that 2-finger separation. And some of the time, 50% of the time, we can't. And that's where we're really going to focus on just making sure in all cases that we're really tensiling those tissues appropriately. We'll go over postural retraining. Sometimes we'll do abdominal soft tissue mobilization. So those rectus abdominal muscles, those six-pack muscles, if there are trigger points in those muscles, that can really keep them from working effectively and efficiently. So sometimes it is necessary to do some massage to those muscles to actually get them to release, to relax, and then to function appropriately so we can strengthen them in a better alignment. And then again, kinesiotaping is something we can also do. This is the picture I was talking about earlier, and I think they do a very good job of showing what our new goal in PT has been over the last 10, 20 years. So the top picture kind of shows what the rectus abdominis look like at rest in somebody who has a diastasis. So there's an ultrasound picture, there's kind of the drawn picture, and just a picture on the other side. And at rest, you can see there's a separation, but everything's not necessarily tense, but it's in line, essentially. The next one is somebody doing a crunch or a curl up, and this person has a very good demonstration of that concavity. There's a big dip in between those muscles. And the linea alba, the tissue in between the six-pack muscles, is kind of sagging down and dipping. So there's really not good tensile force in between. And that's usually because we are not using our deep core stabilizers. And then that last picture, you can see, so they called it TRA curl up, and that's essentially they're using their transverse abdominis, their deep core muscles, to stabilize before they do a curl up. And that concavity is now gone. They are controlling their intra-abdominal pressure much better. And so that's just a really good stepwise introduction as to what we're now currently trying to do with rehabilitation. And sometimes that does help close a gap, and sometimes it doesn't. So again, it's kind of that 50-50 chance of what's happening there. Let's see. There we go. Okay. So finally, we have the myths about the diastasis recti. These are some things that I commonly hear. There's quite a few more things out there. If you have things, please feel free to put them in the chat if you want to discuss them. But commonly I hear, well, I can't do planks again, or I can't do crunches, or I can't do X, Y, and Z exercises that I used to do. Planks is a pretty common one that I hear, and I've also seen this on a number of sites, and that's not necessarily true. Your body is designed to do a bunch of different things, and you know, with the correct training, honestly, I think that even if you have a very large separation, you can do the planks again if you are doing them well. They are more about functional stability. It's more about regulating that pressure, and if you can do that, you're not going to be doing harm to or widening the gap, essentially. The most important point is really, can you functionally do them well? And that really applies to anybody, regardless of whether they have an abdominal separation or not. Another thing I hear is it only happens to women. Not true. It happens to anybody. Anybody with an abdomen can have a separation of the rectus abdominis muscles. I think we commonly hear about it in women, and I think women are a little bit more aware of the separation, especially in regards to pregnancy. It's covered in a lot of pregnancy books. It's something that they're told to watch out for. It's something that they are assessed for typically after they've had the baby or in their postpartum time. But this happens to men as well. I have plenty of men who come into the clinic and have a diastasis. Typically, though, I don't think they're as aware of it, and it's usually not the reason that they're coming in. Typically, it's because of another issue, and we just happen to notice that they also have an abdominal separation and have some core weakness that we need to address. And like I talked about before, all babies have it. Babies are born with a diastasis, and as they get stronger, that closes. I need surgery if the gap remains. We addressed this a little bit earlier, so I don't have to go too much into that, but now surgery is more so for cosmetic reasons. There are some people who unfortunately don't have great integrity in their connective tissue. Everyone's a little bit different, but some people will have a lot more laxity in that tissue in between the linea alba, and they're always going to have that laxity. And so sometimes surgery is a really good option if that is really bothersome, but you can still have really good function without surgery. So you don't necessarily need surgery, but it is an option. You can absolutely have that if you want. It's not a need. And then a diastasis is not the same thing as a hernia. A hernia is an actual hole in the connective tissue or in the muscles where typically bowel is coming through that. The diastasis is not, it's not a hole. It is a stretching of the connective tissue. They can exist simultaneously, but a true diastasis is really just the stretching of the connective tissue between the rectus abdominis muscles. But their rehab is typically very similar, where we're really addressing that intra-abdominal pressure. The more you can regulate that, the less you're going to have any pressure kind of coming through that weak tissue or that hole. So those are just some common myths that I tend to see. And I think I went pretty fast, but I wanted to leave some room for questions if you guys have any. Let me see if I can pull up the chat now. All right. And again, feel free to unmute yourself. Yes, this presentation will be online for later viewing. We're recording it currently, and it will be on our YouTube channel, which is also in the chat. Go through, I have some references, and I just want to put my contact information up there if anyone has any questions that come up later. Absolutely, recommendations to prevent this from happening. So I think the best thing would be if really working on your core strength and knowing kind of where you stand. We really want to make sure that your abdominal wall is strong. We want to make sure that your pelvic floor is strong and that you're doing exercises appropriately. To prevent this from happening, it kind of depends on what you're doing that could cause it to happen. Are you planning on a pregnancy? If so, working on core strengthening throughout the pregnancy, maintaining activity levels throughout the pregnancy can be very helpful. There are certainly things that you can do just activity-wise to make sure that you are, so for example, if you are pregnant, knowing that a separation is part of pregnancy, making sure that you are not doing things that can progress a separation. For example, sitting straight up out of bed, that's a sit-up, right? And the sit-up can actually increase that pressure and push things forward. So times when you find that you're sitting up just during your activities of daily living, getting out of bed's a great one. Instead of just sitting straight up, maybe rolling onto your side, log rolling and pushing up. So you're not engaging your muscles in a way that's going to be more detrimental. Other things that you can do if you are trying to avoid diastasis would be with exercises. So making sure that you're doing exercises appropriately. I'm going to use the crunch. I'm just going to pick on the crunch for a little bit. I'm sorry. It's just a very easy one to pick on right now. So if you are doing a lot of crunches or curl ups as an exercise, you want to be really cognizant about if you're holding your breath. So think about that. If you're holding your breath, there is no way as you crunch up and decrease that intra-abdominal space for the pressure to escape. It has to go somewhere. If there's any weakness, it's going to try and push through that area of weakness. If you are able to breathe through exercises, and I know there's a lot of different techniques out there for breath holding as well. You know, sometimes those are really good, sometimes those are not so good. It really depends on the person, their strength and their tissue integrity, essentially. But I recommend breathing through exercises because as long as you're able to release that pressure, now your your intra-abdominal pressure is reduced. So even if there's more pressure through one area, it's not going to be as significant as if you were holding your breath. So there's a lot of different things, and it really depends on what you're doing specifically to kind of prehab or prevent, if that makes sense. Okay. How soon after pregnancy would be appropriate to test for a diastasis? I mean, you can do it right after pregnancy. You can do it within the first couple of days. However, a lot of that is going to, it's going to heal on its own. So you're probably going to have a fairly sizable diastasis week 1, and it's probably going to improve over the next 6 to 8 weeks. I would definitely recommend at least checking it by 6 to 8 weeks. So that's typically when they go in for their postpartum follow-up visit, and that should be at least the first time they check it, but not the last. Typically between delivery and the first 3 months, we see a really good amount of recovery. But if you have a little bit of separation around 6 weeks, keep monitoring or go and see somebody if you are worried about that or want to try and re-engage your abdominal muscles or start working on core strength. Typically around 6 weeks is when I start to see women postpartum because they've done a good deal of healing and we can really do a little bit more at that point. Okay. Is it difficult to improve your diastasis recti if your last pregnancy was 3 years ago? I don't think time really makes a big difference, whether your last pregnancy was just a couple of months ago versus 3 years. Typically, the reason why, so again, we've talked about 50% of the diastases will go back together completely and 50% of them won't. So it's never too late to go ahead and get that separation addressed. Will we actually be able to close it? There's always a 50-50 chance. But more likely what's happening at that point is that those deeper muscles, especially if you've had a couple of pregnancies, those deeper muscles can be really, they were overstretched for a while and then they kind of came back. And oftentimes they just forget how they're supposed to function effectively because they've gone through so much change. So very frequently in regards to pregnancy, those muscles just need some more education, some re-education to get them to engage effectively, to make sure that maybe it could be pelvic floor too. We want that pelvic floor to be engaging really well because that can also apply some tension through the abdominal muscles. So difficult, no. I think it'll be functional. It'll be a functional improvement that we're looking for to try and get those deep core muscles. And hopefully we can see some improvement with the separation as well. Okay. What are some exercises that can contribute to diastasis recti? Oh, that's a really good question. I think it's actually how you do the exercises and not so much which exercises specifically. So going back to what I was talking about a second ago, so breath holding, Valsalva maneuver, those things where you get a lot of pressure through the abdomen. If you combine that type of exercise with weak core muscles, then you're going to be more at risk for having a separation. So that can be a lot of your heavy weight lifting, right? That can be maybe starting off a little bit too vigorously if you haven't been used to doing a lot of exercises before, where it's challenging enough that you feel like you really have to hold your breath through it. Doing that here and there, that's probably not going to contribute. If that becomes your norm and you're doing it for years, having a little bit more of that breath holding, doing exercises that increase your intra-abdominal pressure, those are going to be ones that contribute to diastasis a little bit more. I feel like I'm not explaining myself very well, but I hope I am. But a lot of that tends to be more of a combined issue where, you know, maybe you have an athlete that just hasn't focused on their core as well, and there's actually some weakness. And then we're doing a lot of high level activities on top of having some of that abdominal weakness, and that can be more of like a recipe for developing a diastasis. Very good questions. So I think that I have addressed the questions on the chat. You're welcome. If you guys don't have any more questions, contact information is here if you ever want to reach out to me. Otherwise, thank you so much for attending. It was great to talk about this. If you know, again, there's a lot of variability on this topic, and I'm trying to give you what's most recent, but otherwise, I will say goodbye and let you guys off early.
Thank you so much, Abby.
Thank you.